welcome everybody to the practice session. We consider this is our hour of fame. They've given us an opportunity to present some information. We hope that you guys find it interesting. Basically, this is about trying to get paid for your value and how to get what you are worth in our current treacherous environment. The summary for this session is we're all screwed, and then we can go home. And then we'll see if you can adjust that, maybe if you're lucky, smart, or a great negotiator. John Bleacher is he's the co-chair of our committee. We're going to moderate the session. We have a number of different speakers, and we'll kind of go through all of them. But we have a tribute to Dr. Dick Ellis, who's actually, we're lucky to have him here with us today. Can you stand up, Dick? And the video was produced by Chip Uffman, who works there in Texas with him. Thank you.
Dr. Dick Ellis was born in Muskogee, Oklahoma in 1928. He moved to the Texas Panhandle in 1930. After completing high school, he entered Baylor University in Waco for pre-medical education and graduated from Baylor College of Medicine in 1952. During medical school, he spent 2 summers as an extern at the Wichita Falls State Hospital. Following his internship at the St. Louis City Hospital, he married his wife Kay and entered the U.S. Air Force. He was stationed in London as commander of the 3911th U.S. Air Force Infirmary. While there, he and Kay welcomed their first son, Derek. They would later have 2 additional children, David and Anita. After 24 months, he returned to St. Louis and completed his general surgery residency. During his time there, he developed a lifetime friendship with Dr. J. Eugene Lewis, the first pediatric surgeon in St. Louis. Dr. Lewis encouraged him to pursue pediatric surgery and assisted Dr. Ellis in getting a fellowship position with Dr. Clatworthy at Columbus Children's Hospital. In 1965, Dr. Ellis started practice in Fort Worth as the first pediatric subspecialist in Tarrant County. In order to build his practice, he was available 24/7 for the emergency rooms of 2 local children's hospitals.
I was on 24/7, but I had the excellent help I told you about earlier this morning, and those were some of the best years of my life because I was really the boss, and the hospital was practically mine, and no one questioned me very much. Yeah.
He quickly became chief of surgery and later chief of staff of both. Over the ensuing years, he was instrumental in recruiting neonatologists and subspecialists in gastroenterology, radiology, and anesthesia. In addition, he expanded his own group to a total of 5 pediatric surgeons. One of his greatest accomplishments was his involvement in facilitating the merger of W.I. Cook Memorial Hospital and Fort Worth Children's Hospital to form the modern-day Cook Children's Hospital. Multiple prior attempts over 40 years to merge had been unsuccessful. Dr. Ellis was able to convince the Board of Trustees to approve the merger of both medical staffs in 1982. Shortly thereafter, he was elected president of the medical staff of the new unified Cook Children's Medical Center. Using his connections and previously formed relationships from APSA, he was able to develop pediatric trauma and oncology programs at Cook Children's. Dr. Ellis's influence extended beyond Fort Worth. He established the Texas State Society of Pediatric Surgeons. He served on multiple committees of APSA and the AAP surgical section. He served as APSA treasurer from 1978 to 81 and again from 1984 to 87. To this date, he is the only APSA officer to hold the same elected office twice. He was AAP section chairman from 1988 to 89 and APSA president from 1992 to 93. No other Texas pediatric surgeon has served as APSA president, nor has any other APSA president been primarily based in a non-academic practice. During his career, Dr. Ellis served as ship doctor on the small sailing yachts Sea Cloud and Sea Cloud II. He completed over 20 trips. Both ships are still in service today. Although he retired in 1995, a year later he recertified in pediatric surgery, extending his certification to 2008. He still attends grand rounds at Cook Children's regularly.
I really do feel privileged to have been a physician. I'm proud of my profession. I like having peers like you, and it's really been a good deal for me. Yeah.
I love these tributes, and thank you so much for all of your contributions, Dr. Ellis. I really appreciate it. And I would say that in those days, it was very difficult to walk uphill in the snow both ways with your feet wrapped in newspapers, because they probably didn't have snow in Texas. But the contributions are certainly very appreciated. We have a couple of quick questions. I don't know, hopefully you got some of your buttons. We have a couple of quick questions before we get started. Can we have the first questions, please? So does everybody have buttons? If you didn't, there's still some more out in front, or maybe there's still some more out in front. So questions are you employed or in your private practice? Okay. Results of survey. Hello? Oh, there we go. %90 employed, 10%. That actually somewhat mirrors our membership survey that we just did in January and February, although even a little bit more. You know, this 15 minutes doesn't include this. Can we shorten the time? Can we shorten the time a little bit for the response? Next question, please. Are you familiar with the current movement from volume to value? %63% yes, 38% no, which I find interesting because everywhere else in the world other than pediatric surgery, this has been on everyone's lips for 5 to 7 years now. Next question, please. Is your compensation linked to value metrics, yes or no? Um, 72% no. Interesting. Just think how much fun you're in for today and in the future going forward. So if so, what proportion of your income is value-based? For those of you who do have value-based contracts. Can we make that a 10-second response time for the rest of the questions? You can't do that? You can't change that at all? So it's kind of across the board. Okay, thank you. So let's start first talk. So it's getting paid for your value. This is my talk. This is an overview of the current state of payment. This is the kind of stuff, and I'm going to apologize. Some of this stuff we're going to go through very quickly because a lot of this stuff, they spend literally, you know, they have 2-3 day seminars discussing the implications of MACRA and some of the recent legislation. So we'll go through it to try to give a basic background and, give you some idea of what's going on. Historical background of physician payment, you notice I don't say reimbursement. Reimbursement is a term we should stop using because reimbursement means I laid out the money and you pay me back. What we're doing is getting paid for whatever it is that we're doing. So we should use the term payment, okay, rather than reimbursement. There was an old story when I was in medical school. They used to say, oh, you know, in ancient China, the doctors were paid, proactively, and if the emperor got sick, they stopped getting paid. Turns out it's a total myth. So basically, for almost all of history, doctors and other people who are providing health care were paid for their service. You can call it fee for service or whatever, but if you did something, someone paid you, whether it was in the coin of the realm or chickens or, baked bread or, they took care of your kids, whatever. It was always being paid for by something. Employer-based care, there's an interesting history behind there. Kaiser actually was a shipbuilder and he was able to finagle a contract to build the Grand Coulee Dam, and he had to relocate a lot of employees into the middle of nowhere on the Columbia River to build the dam. he had, in order to get them to come there, he had to provide health care for them and their families. And that was kind of the start of Kaiser, actually. Employer-provided health care was accelerated in World War II, where they had price controls. And it wasn't until the mid-1960s and the Johnson administration, with the war on poverty and with the decision that they were going to subsidize health care for the elderly and for poor people, where Medicare and Medicaid came into being. Okay, so that was legislation passed in like 63, 64, something like that. Interestingly, immediately led to cost overruns. The cost overruns were astronomical. It was estimated, I think the number was about $42 million the first year, and ended up being something like $250 million. The next year, they estimated $250 million, and it grew to like $800 million. It became exponential growth. Sound familiar? And what happened is that these cost overruns in the Nixon administration led to the creation of a word called healthcare reform. Never in the history of healthcare had healthcare reform ever become an issue until the government got involved. And that leads to a whole bunch of other consequences, sustainable growth rate. We'll talk about some of these other things in a couple of minutes. So, financial writer that I like to quote Malden's rule of thumb concerning unintended consequences. And for every government law hurriedly passed in response to a current or recent crisis, there will be 2 or more unintended consequences which will have equal or greater negative effects than the problem it was designed to fix. So these will all be available. Slides should be available, so I'm not going to read all of them. But basically, everything that happens has unintended consequences, and we're still seeing the effects of that now. So managed care, they had some HMOs. New York had a health insurance plan. Kaiser was a managed care program. In the 1990s, they were talking more about healthcare reform because the explosion of healthcare costs was unsustainable. So everybody, even though they never passed major legislation, everybody moved into a managed care model where you get capitated payments are provided to primary care doctors. There's a gatekeeper who then decides who needs advanced care. Part of the problem was that the gatekeeper had their fingers on the scale. They made money if they saved money, and they lost money if they spent too much. There were no quality metrics, so in other words, they could send to the cheapest person who was going to provide the care, the cheapest hospital. What it did was it squeezed the fat out of the system. It reduced hospital payments by 25% because the insurers, everybody wanted to keep their market share, so everybody negotiated cutthroat deals. Doctors signed on to be on panels at markedly reduced rates, and nobody was happy, and all it did was it squeezed the excess out for 4 years. And then the pace of growth continued at exactly the same rate. So really, all it did was it set the payments back for 4 years, but growth continued unabated. So the problem with Medicare was that they passed, as part of Medicare legislation, a sustainable growth rate, which meant that any increases in utilization required a budget neutrality. So if urologists did twice as many prostatectomies, since it had to be budget neutral, what they had to do was they had to lower the payment for doing a prostatectomy by half. Okay? That obviously became a problem because if you're a urologist and you're relying on your doing prostatectomies and suddenly your payment for doing a prostatectomy gets cut in half, how do you respond? Well, they attempted to fix that. All right, and eventually what happened was that they passed a Medicare Correction Act. It's called MACRA, and we'll talk about that in a little bit. But the sustainable growth rate, every year Congress had to pass another law to overturn that and basically continue people's reimbursement or payments at the same level. And every year that deficit got worse and worse and worse to the point where if they ever let it go through, it was going to decrease people's payments for procedures by about 50%. It got really ridiculous. So they had to fix that at some point. And then on top of that, we throw the Patient Protection Affordable Care Act, which attempted a major overhaul. It included things like quality components as well as payment reforms, was trying to do cost reduction through insurance reforms. So this is really an healthcare insurance regulation. And it also started the development of accountable care models where an organization is paid a certain amount of money per member per year or per member per month to take care of a certain population. And then what happens is that you are now responsible for providing all of the care for all of those people for that period of time. So everything that you do now becomes a cost center instead of a profit center. Also in that time frame, Don Berwick, the head of what was then CMS, came out with the triple aim. The triple aim is reduced per capita cost, improved patient satisfaction, and improved quality of care. If you take an MBA course, what you will find out is that there's this thing called the iron triangle. The iron triangle affects everything. It affects business, it affects healthcare, it affects everything. Okay, you can get something faster, you can get something cheaper, okay, and you can get something of better quality, but you can't get it all three at the same time. It doesn't happen. It's a physical, financial impossibility. So you can't lower cost, improve quality, and get better care and better patient satisfaction. It's not going to happen. However, that's our goal, is the triple aim. And because it doesn't work, and we've done a few other things that you will see about in a second, what's happened is that we've also come to a point where they had to add a fourth aim, so it's now the quadruple aim, and that's better provider resilience and better provider satisfaction. Unintended consequences. So while you were sleeping, maybe you wish you were wondering where EHRs fit in with all this. Well, you weren't. Well, you should have been, because with the shovel-ready projects in the American Recovery and Reinvestment Act in 2009, it included the HITECH Act, which is where we got EHRs from. Dr. President Obama said, to improve the quality of our health care while lowering its costs, we will make the immediate investments necessary to ensure that within 5 years, all of America's medical records are computerized. It will cut waste, eliminate red tape, and reduce the need to repeat expensive medical tests. And it won't just save billions of dollars and thousands of jobs. It will save lives by reducing the deadly but preventable medical errors that pervade our healthcare system. And we've seen how well that has worked out, haven't we? So that includes meaningless use 1 and 2. And since that included things like you had to do a certain number of electronic order entries and medication orders to pharmacies by electronic means and electronic patient communications, had a whole bunch of metrics that you had to satisfy in order to get a bonus. And it was working so well that they decided to hold off on doing level 3, which would have required penalties as well as bonuses, and that became MACRA. So MACRA was passed in 2015. That was the Medicare Access and Chip Reauthorization Act. And that was a major overhaul of Medicare payment, required 2 tracks. One was the merit-based incentive system, which meant you had to track your own quality metrics, and you got paid they withheld money from you, and then they paid you a little bit more if you met those metrics. If you didn't meet the metrics or you were below a certain threshold, you actually lost money. And they also came out with advanced alternative payment models. Then, as a result of EHRs and all these other regulations, then they decided that maybe the Office of the National Coordinator decided they needed to reduce physician burden. So there's now a move to reduce physician burden that has been imposed on them. Can you say unintended consequences again? From the imposition of EHRs that were really not ready for prime time. So we have now a transition from volume to value. Volume is fee for service. The more you do, the more you get paid. And the theory behind that is that the more you do, if you get paid for doing more, you will make more money. So there's an incentive to do more. In medicine, we're all piece workers, okay? Whether we like to think about it or not, there's only a certain number of patients you can see during the day. There's only so much you can charge. There's only so long that you can work. And what happens is that if you make more pieces per hour, you get paid more. At some point, the only way to satisfy that is to work longer hours. And again, the incentive theoretically is to drive people to do more work. If you need to make more money, you're going to do more things. So we're trying to get away from fee for service. Even though that's the way it's been done for all of eternity, we're now changing that model. Value is where we're trying to go to, and it's defined by the equation value equals quality divided by cost. So if you want to get more value, you have to either increase the quality or lower the cost. So the future of medicine is going to be determined by providing value-based care. This is where we're headed. Everybody's talking about it. It's on everybody's lips. So is the future here? I'm not going to go through this whole thing, but this is a listing of the advanced practice models that are now available. And you can eventually look at the slide, and basically it includes 3 generic types of things: bundled payments for certain diseases, or bundled payments for like joint replacement, for example. This is from the Medicare website, by the way. You can find this easily. There are advanced, ACOs, accountable care organizations, that are now sharing risk as well as sharing savings. So if they make money, the ACO makes money. And where does that leave us? Well, value-based care at this point is hardly that. Another dirty little secret is that most hospitals and providers actually don't know their real costs. If you don't know your real cost, you can only use price as a proxy, and that's not an effective way of figuring out how you're going to cut costs, because if you're just aggregating costs and selling stuff like hospital beds, et cetera, you don't know how to really save money. Primary care can be capitated, but specialists with sporadic care, you can't really do that, okay? So people like us, how do they figure that out? Even if you have bundled care, for example, the global price is bundled. So how is that divided up? Who decides who gets what piece of that bundled care? You get paid $30,000 for a joint replacement. Well, that includes the hospital stay, it includes the nursing home, et cetera. And how are you going to get paid for that? So most of how they figure this stuff out now is based on you get paid by RVU, or you get paid your base salary. There's some value-based component that can be anywhere from 5 to 30%, but it's chipping around the edges because you're still being paid essentially by fee for service. The good news is there's a lot of leeway in how you get your efforts valued. So you can go on straight salary with some percentage of value component, what I just said a couple of seconds ago. We're going to run out of time. So how do you get yourself valued? All right? Your system or hospital needs you or wants you. Well, they don't really want you, but they want an NICU, they want high-risk OB, they want a trauma service, so they need you to do those things. Your hospital now has to support population health. So your extravagant salary is still less than losing all of their members to send them to a competing hospital system where they lose all control of the costs. So remember this. For now, we are a profit center. We are changing from a profit center to a cost center. This was a recent study, just came out. I added this slide in here, even though we have a couple of seconds left. For cardiology, for example, the average salary is $590,000. They generate $3.48 million a year. So all these specialists, including us, if you look at, Charlie Stoller did this, we provide trauma care, et cetera. And you can see here on line 2, pediatrics in most health centers, 5 to 10% of hospital beds routinely account for 25 to 30% of the hospital revenues. And they need pediatric surgeons to do that. However, in an accountable care effort, they need you to provide those services on the one hand, but on the other hand, your salary is now a cost center to them. Okay, and since services may not be able to be cut, and since they can't cut nursing salaries, the most easy target is physician salaries. And now that we're all employees, we are losing our leverage to be able to control that. So your ability to get paid going forward will depend on your ability to demonstrate your value to your hospital system and your group. And we have 2 quick questions, and then Duncan's going to talk about negotiation tactics to accomplish this stuff. So can we have the next 2 questions, please?
So question one, have you already participated in a pediatric surgery employment or contract negotiation prior to today? 1 yes, 2 no. So 2/3 of the people here already have done this. 1/3 have not. Good. Next question, have you received detailed instructions and or advice during your residency or fellowship on how to do these negotiations? If you haven't, then I'm really glad you're here. And not surprisingly.
I think that says it all right there, Duncan.
Yeah, great. All right, so we can go to my slides then. I wrote this primarily thinking of what I didn't know as a resident and fellow, but I'm hoping some of this will be applicable to some of you who are mid-career as well. It's this one?
Yeah, forward is this one.
Okay. I have no conflicts of interest. I never went to law school. I never took a single law school course, although my daughter's an attorney. And these opinions are mine and don't necessarily represent who I work for, because I'm an employed physician like many of you, nor do they represent the opinions of APSA. This book was recommended to me by Barry, and it is fantastic, and I would highly recommend it. Never Split the Difference, and it's the key to how to do thoughtful negotiations. And it's written by a guy named Chris Voss, who used to be a lead negotiator for hostage situations for the FBI. So when Americans were taken hostage by evil, terrible terrorists and criminals, he would be called in to try and negotiate their release. So you can learn a lot about dealing with hospital administrators by reading this book.
I was going to say that.
I mean, and I'll steal a lot of his ideas, and I'll show you those on the slides. Okay, and I have 12 basic suggestions, or what I would call rules. Number one, when you go into a negotiation, you're thinking about an employment contract, going to work for a hospital, always hire an attorney. This guy's my attorney. I mean, there are millions of attorneys out there. Find someone who has employment experience, who negotiates contracts and is a contract attorney, not necessarily your local ambulance chaser or something like that. And make sure there are no conflicts of interest. What I mean by that is that many really good attorneys in your city or in your town may have been on the board at your hospital, or may be best friends with the CEO, or may have actually represented your hospital in various lawsuits. So you may have to go geographically an hour and a half, 2-hour drive from your hospital to find a really good attorney who does healthcare negotiation and contracts, who doesn't have some sort of personal relationship with people who work at your hospital. And depending on the geographic area where you work, you're going to have to shell out somewhere between $4,000 and $10,000, even if it's your first contract right out of fellowship. So you have to kind of budget for that in your family budget. Rule number 2, learn all about who you're going to potentially work for, because well-informed is well-armed. So you really need to know more specifically about pediatrics and pediatric surgery and the surgical environment of that local area where you may be working than your employer does. So learn about the competition, learn about the alternatives to either joining or signing, and come up with what they call a BATNA, which is your best alternative to a negotiated agreement. And that's not necessarily your fallback if you can't negotiate a contract and you decide to work somewhere else, but really try and figure out what will happen to the children and to the people of that area if you don't negotiate that contract and if you decide not to go there. Find out what your best alternative is for you and for the kids. Rule number 3, which I never thought about before talking to Barry, which is to talk to your future partners and associates. You may go to work for a large university or a physician group. I work for a group of physicians. There are 260 of us, but there are 4 pediatric surgeons, and it's extremely helpful to talk to the other pediatric surgeons who have already gone through this process, who know about what the benefits are, what the perhaps problems were with the negotiations that they went through, and the lessons that they learned working for this person who may be your employer in the near future. This is very helpful, I think, to those of us who do surgical training. A negotiation is not an operation, meaning that when you go in to talk to your potential employer and you're negotiating a potential salary or a contract or whatever, you have this mindset that you're going up against a disease, like a Wilms tumor or like an esophageal atresia, and it's really not your employer. The person who you're potentially negotiating with is not, believe it or not, a disease or an illness. The adversary is the situation, and this is what Voss tries to teach in his book. The situation is having inadequate pediatric surgery coverage for a population of children in a certain area. And so your potential employer is not your adversary. Your potential employer is someone who you're trying to work with to solve the problem, which is the adversary of inadequate coverage for children. And so you sort of team up with your potential employer to negotiate a good contract to solve that problem. There's no winner. Because remember, if you sort of screw your potential employer, you convince your employer that the average pediatric surgeon makes $3 million, and you negotiate a contract to get paid $3 million, eventually that lie will be discovered. And that's someone who you're going to have to work with every day, who's not going to then trust you in the future. So you have to be honest, and you don't win a negotiation. You come to an agreement to defeat the adversary, which is the lack of adequate coverage. Be passionate, but don't be emotional. I mean, you can speak passionately about your love of caring for children, but don't start screaming and yelling and breaking down when things aren't going your way. All right. Every word counts, and this is especially important for pediatric surgery. You need to know what your call responsibilities are, and you can get it written out for you, no more than 4 every 4th night or no more than every 5th night, something like that. Will you have locums coverage if you end up with inadequate coverage? So if you're joining a group of 5 and 2 happen to retire or leave, you should have written into your contract then that locums coverage will be paid for. Are you going to have nurse practitioners or PAs? If so, how many? If you're going to an academic job, I have a very good friend who almost took a job in pediatric urology at a major academic medical center, and he was told, oh, well, there would be adequate protected time, but they didn't tell him exactly how much, and he didn't sign the contract because he wanted to know exactly how much protected time he would get. Will you have research funding? And if someone says, well, you know, we have a generic contract at the university here, there are 900 physicians, and you know, that doesn't really apply here, this part of the contract, which applies mainly to the internal medicine guys and not really to the surgeons. Well, if it doesn't apply to you, ask them to remove it from your contract, and they'll do that. All right, many contracts now, especially those at academic medical centers, are standard. So it is a standardized contract, perhaps it's 8 pages long, and you're negotiating that, and they just write in under department pediatric surgery or general surgery, and then they write in under name, they write your name. Many have annual renewal clauses, and so tenure is really no longer what it used to be. And even if it is what it used to be, let's say you're in a tenure track position and you get tenure, what tenure guarantees you is the bare minimum salary. So at many academic institutions now, you negotiate to be in the tenured contract because you think that's going to guarantee you your full salary, and it's really only guaranteeing you the basic minimal salary, the amount of money that's necessary to get health insurance coverage or something like that. Standardization does not prohibit you from adding or subtracting things that are important to you as a pediatric surgeon. And I know that I did this when I negotiated my contract with my current employer. I pointed out things that I thought were problematic and that my attorney thought were problematic with the generic contract, and sure enough, the next year, those were changed for all 260 contracts. So what I was able to discover with advice from my attorney were things that then helped everyone in our group the following year. Most standard contracts, as Barry mentioned, now have citizenship or quality or value metrics, and you really know what you need to have them specify, if you can, what those are. Are they finishing your documentation within 24 hours or 48 hours? Are they having you go out to community pediatricians to do outreach visits? If so, how many are you supposed to do, and how often are you supposed to do them? Are you supposed to give a certain number of grand rounds talks at local hospitals? And a lot of times this will all be spelled out in an appendix or in a supplement or in an addendum at the end of the contract. And it's important when you negotiate to ask them to show you that, and ask them to show you the specific ones for pediatric surgery. Find out again, as Barry mentioned, are you on a straight salary, or is it a salary plus bonus, or is it completely RVU based, and get them to tell you how often this might change when you're negotiating this salary. All right, in my opinion, and this is just my opinion, initial salary should be guaranteed if you go to work for a big physician group or university. It takes, for those of you who are in training, it usually takes about 2 or 3 years to establish a clinical practice these days, to get your name known in the community, to get the pediatricians familiar with you, to realize you're not some crazy lunatic, that you're actually a good doctor. Unfortunately, payments from many private insurers will often lag 18 to 24 months, sometimes even longer. So administrative errors always occur. Somehow they'll put down Blue Cross Blue Shield will have your wrong first name or your wrong social security number, or something will happen where there's a significant delay in the initial payments for services that you are providing. So most contracts now, when you negotiate, will offer you a 2-year guaranteed salary, and in my opinion, it's not unusual for you to ask for a 3rd year, to say, I would love to work for you, but I'd like to get a guaranteed salary if possible for 3 years. And if you have a contract which is a straight salary plus bonus, make sure that you are bonus eligible from the start if you can do that. In other words, if one of your partners ends up getting sick for some reason, and you end up having to take more call than you expected, you may end up able to generate much more revenue for the practice than you expected. And so if you're bonus eligible from the start, you can actually capitalize on that. Rule number 8, calculate your own salary. And so all of these things are publicly available now on the internet. You can go to the MGMA website and you can figure out what the typical pediatric surgeon gets paid. Sullivan & Cotter, which is a consulting group, has various surveys. Sometimes you have to pay for these. Sometimes you can find them on the internet. Sometimes you can get them from your friends. And there are also websites that compare relative costs of living. So for example, if you are changing practices, you started in New York and you're moving to Oklahoma, you can go to websites and find out what an equivalent cost of living would be for an equivalent salary. Pediatric surgery is unique. If you're expected to provide a certain list of services, you should try to define those if you can. So when you're negotiating perhaps a salaried contract to provide all pediatric surgical services in a certain community for a certain period of time, find out if they want you to cover testicular torsions, if you're responsible for doing those. Find out if you're supposed to do esophageal foreign bodies. Sorry, I should finish up. Find out if you're supposed to do non-operative management in your clinic. Find out if you're supposed to do PDA ligations. And this is especially important if you're doing capitation. Last few rules, as Barry talked about, were important for the value proposition, because we're available, and you may need to point this out in your negotiations when you're negotiating your salary, that sometimes the number of RVUs you produce don't necessarily cover your salary, but you provide everything else. It's already been mentioned that Charlie Stoller has coordinated a group to study this, and this is several years old now. This is 10 years old, but our value proposition at this time in many academic medical centers was over $7 million, meaning that we generate a lot of revenue for the hospital. And I'll skip over this. Actually, this is the last thing I do want to mention. Understand RVUs. If you're on an RVU-based salary, make sure that there's a fudge factor for certain operations that we do that have no RVUs, such as laparoscopic pyloromyotomies and others. I'm being told that I need to finish. So, the last one is don't be afraid to walk. This is for the residents and fellows. You know, the biggest change in employment is when you sign for your first job after fellowship, and the second biggest change in employment is at the end of 2 years when you discover that you made a little mistake and it's time to get a different job. So renegotiate a different job. Thanks.
Thank you. Thank you very much.
The next three speakers are going to describe to us how they make this work in their own practice environment. The first one is Marcene McVay Gillam, who will address the academic.
We actually have a couple of quick questions. Can we get the, do you guys, the audience, do you have a strategy to calculate your potential salary? Not surprising. Most people haven't really thought about it at this point. And the second question, do you have access to data to support your position of the value you add as a pediatric surgeon to increase your income? Well, hopefully, we can provide a little bit of this, but the answers are not really clear. So it's basically what you're going to be able to work out is pretty much what it's left to. So this is what our next three speakers are, people who've had recent experience with working with this. So Marcene, please.
Yeah, thank you. So within the academic pediatric surgery community, there's a wide variety of different practice structures and interests. And my experience is just a very small example of that broader diversity. But there are more details that I can cover in the 5 minutes, and everybody else is already over, so Barry's going to be kicking me in a couple minutes, but here we go.
No, that wasn't you. I was telling him to start the clock.
So I'm employed by the University of Arkansas for Medical Sciences in a traditional organizational structure. We're a group of 6 faculty. And we represent a range of experience and academic focuses. We represent ostensibly the 4 current tracks in our university, including basic scientist, clinical educator, and clinical attending. We also support a specialty training program that graduates 1 fellow a year. And as you can see, we also have a set of diverse interests and roles in the hospital. So it's important to understand in our environment that we have 2 different practice locations, and that comes into play for me specifically. The main hospital has been in place for over 100 years. It's our tertiary referral center. It's an ACS verified level 1 trauma center. All 6 of us practice there, but last year in February of 2018, we opened Arkansas Children's Northwest, which is a freestanding pediatric regional subspecialty hospital, and that's where my primary practice is. It's important to understand that this is a 3-hour drive from our primary hospital, and so we really have to function on our own and not just like a satellite. Our current practice is a result of about a century of collaboration between UAMS and the Children's Hospital. The newly formed CHPC, or Child Health Practice Collaborative, really is to our benefit. It makes physicians more directly involved in the workings and the negotiations between the 2 facilities, and really helps with planning across the institution. For those of us who are employed by UAMS, but are primarily focused on pediatric care at an alternate site. There's a complex interplay between these 2 regarding responsibilities, mission, and funds flow that's reflected in our annual operating agreement. But we also have a common mission, which includes excellence in patient care, in education, and in research. And before the expansion into a hospital system, all of the physicians that practiced at the Children's Hospital were employed by the university and were incorporated under the CUMG. With the expansion to two hospitals, though, Arkansas Children's has now developed its own practice medical group, and it's going to be interesting to see through the years how that plays out. But the CHPC is really integral in the discussions about how those practices are going to evolve. Maybe. Wrong one. There we go. So under CUMG, the new plan that was submitted last year and is in current negotiations is based on an individual equation. So for 1.0 FTE, your compensation is going to be based on a national average of RVU based on AAMC data. Depending on what your medical specialty is, your faculty appointment, and your time in position. There also is some credit to be gained from non-clinical work, which is primarily based on funded things, so funded research, reimbursed hospital positions, and a very small amount that's credited towards education. As you can imagine, it's really popular. So all of those things add up to your individual output, and it's been recommended that you have a salary adjustment if you are an overperformer or downwards if you are an underperformer. However, this is only based on the pool of available funds within our department. So if everybody in the surgery department is an overperformer, then there aren't funds necessarily to increase your salary. So this is another thing that CHPC is really actively involved in. A lot of details that get very granular about that that I don't have time to go into. So for me personally, I was hired for program development at the new hospital. I'm an assistant professor, a clinical attending non-tenure track. My position was entirely new, an entirely new facility. There are no comparables across the university, many unknowns, and so they just sort of guessed, okay, I'm going to be 100% clinical. I knew that was not going to be the case. I was going to have a large amount of administrative responsibilities within the hospital. And so I did negotiate for a three-year salary guarantee that's actually paid from the hospital to the university to pay me, which is an interesting arrangement. But I also really fought to get it based more on MGMA data than AAMC because of my large volume of call responsibilities, the fact that I'm in a smaller community and would require a whole lot of administration. So in reality, I'm about 50% clinical. I, in the first year, did between 350 and 400 cases. I spend about 15% of my time at the main campus, which requires some travel. The rest of that time is a lot of administration. Most of it is really focused right now on program development for the trauma system, as well as quality work. So as a group, with this new arrangement, we decided that we would bargain as a single entity, but what the catch to that is that I'm in a 3-year exemption. And so currently the RVUs that I generate when I'm at that 15% of my time at the main hospital gets credited towards the group for their RVU requirement. We did negotiate some FTE allocations for the different roles that we have. Personally, when I look towards the end of my 3-year exemption, I do have enough RVUs to maintain my current compensation. I track that on a regular basis. I told you I was going to get kicked. So I'm also currently prepping for promotion. And so what that does is really make me write down everything that I do and be able to put a value to that. My hospital administration is very supportive. I'm also a known entity, and I provide value to the hospital in both tangible and intangible ways. I talked about a lot of call that I take, a lot of administration that I do, but when you consider the alternatives of other people that would potentially come into this community that are not as known, then that really is a problem for the hospital as far as recruitment.
Ravi, are you here? Here, come on up. You're up. You're up,
So
and
I'm done.
we're running late. Yeah, right. Sorry. I said
right.
5 minutes and I pushed you off. You got 7. So, thank you very much. Thank you. You know, it's not that she doesn't have really important stuff to say, but we wanted to leave enough time for people in the audience to comment on their own experience as well. So we're trying to keep on time, even though we're running a little bit behind. So. Sorry about that, but Ravi?
Yeah, I'm Ravi Vegunta. I'm Division Chief or Physician Lead as they call in my group. I'm at Banner Children's Cardin Children's Medical Center in Mesa. This is a children's hospital within a big acute care adult hospital. And this whole entity is part of Banner Health System, which operates in 6 states. Our division consists of 6 full-time pediatric surgeons, 4 part-time surgeons, and 10 APPs. We have one third-year surgical resident that rotates with us, and we offer pediatric surgical electives for MS3 and MS4 students for 3 different colleges, and also PA students. We operate in 3 different hospitals. Banner Medical Group is our employer, and our employer presented a new employment agreement for all the physicians in 2018 after almost 2 years of negotiations. Now, they call this a value-based compensation model. But as Barry mentioned earlier, most of the places which are moving to value-based compensation are still predominantly volume-based. There is no, in the new agreement, they offered no guaranteed base salary. Philosophically, most of us became employed physicians because we wanted guaranteed salary, and they took it away from us. The base draw, they don't call it salary anymore, they call it a base draw, that it'll be determined based on prior year's productivity and National Physician Compensation Survey data, and it's adjusted at the end of the year for the upcoming year. 10% of the base draw for us, the pediatric surgeons, is withheld until the end of the year and is given back based on meeting certain value-based metrics, and they call that the value-based compensation. Now, there are multiple national compensation surveys. If you look at the very bottom of the slide, you see the AAMC, the MGMA Academic, Sullivan-Carter, AMGA, and MGMA Private. And based on our group, they decided that Sullivan-Carter fits our group best. This is for the whole medical group, which consists of about 1,200 physicians. And what they did was they wanted to create a hybrid of the national data using a weighted average, where 50% of the weightage was given to Sullivan-Carter, which is supposed to represent us most closely, and 25% each for AMGA and MGMA Private. And they decided to use 2-year rolling average of the hybrid survey data. And the reason for that is to reduce fluctuations, but the disadvantage is that using a 2-year data increases the chance of using outmoded data. They formed a steering committee which included about 10 physician leaders, and I was one of those. And this steering committee approved most of these changes that were discussed over a period of 2 years. And these are the different lanes through which they were going to calculate our compensation. And the most important one is on the left-hand side, the clinical part of it, which they still call it fixed, but there's no fixed salary. It's the base salary. There is a productivity component and a value-based component. There is an element for administrative work. There's an element for strategic work, which they ask. Sometimes they ask us to do certain things, and they attach some compensation for that. The teaching part is blanked out because BMG does not have a teaching lane. There's a special pay which includes excess call pay, sometimes leadership that's done outside the Banner Medical Group. So they decided that the physicians fall into 4 different categories: the volume-based category, capacity-based category, primary care, and shift-based category. And the pediatric specialists, including us, fell into the volume-based category. And then the volume payment is based on 4 tiers. The idea is to push everybody to produce at about 50th percentile or median. If you produce less than that, you get penalized. If you meet the 50th percentile, you get the penalty that was taken out, you get it back to you. And if you produce 75 percentile or more, you get more than what the WRVU compensation value is. And they attached 4 elements for the value-based compensation: economic sustainability, patient experience, access, and clinical quality. Well, we negotiated, and after much negotiation, they gave us a guaranteed salary, but they reduced it by 20% compared to the prior year. After a lot more negotiation, they gave us a guaranteed salary based on the previous year, and that took another 6 months. That brought us to where we are right now. How we got there is, we got here, which is a status quo, and then we only got there because we were part of the leadership, and we were able to negotiate and take a breather, negotiate again, and get to where we are. You have to make sure that they understand the value of the pediatric surgeon, which has already been mentioned before. Thank you very much.
Thank you very much.
Ayla Stanford will describe to us how she makes it work in private practice.
Good morning. In 2006, when I finished my fellowship at Cincinnati Children's, I was in an academic and a community-based practice, and I continued to teach the residents and medical students. I worked with the fellows at CHOP. We continued to be at the surgical forum and so forth. And over those 8 years, two things happened. There were failed mergers, mergers that worked, acquisitions, hospitals were bought out by corporations, and it left for a very uncertain and unstable work environment with mass exodus of many. And the other thing that happened in those 8 years is that I became a mother. And so when one of my sons said to me, "Mommy, are you gonna be home when I wake up in the morning?" I knew that something needed to change. So my goals were, how could I maintain my scope of practice and surgical procedures, be present for my family, have a reasonable commute with a sustainable model, and maintain the income we had become accustomed to. So I started my own private practice. I'm now going on year 3. This is a screenshot from my website. And I went to the community where I started 13 years ago. So I still work in the same hospital, but now on staff there, but I work for myself. A medical consulting company that I also started about 10 years ago because people were often asking me for the best gynecologist, the best cardiologist, where should I go? I incorporated that and started my own consulting business. And then lastly, St. Peter's University Hospital, which is just one state over, asked me to come and help. So at Abington, I have a great working relationship with the NICU. We do all of the bedside procedures. We have a great algorithm that I established 10 years ago. It's 1 mile from my house. So when they call me for biliosymesis or pneumoperitoneum, I don't mind because I go right there. The disadvantage is that I can't expand to all the kids, but I love the fact that my practice here is all index cases. In the surgery center, for the kids that the pediatricians refer to me, because again, they've known me since I started my fellowship, since I finished my fellowship, and I do all my outpatient procedures. The parents love going to the surgery center. They're in and out. There is also peds, ENT, and urology, and again, it's 4 miles from my house. St. Peter's University Hospital, which was a hidden gem, I can honestly say, because it's right down the turnpike. They have a great mix of cases. It's a 50-bed NICU, PICU. They have pediatric radiology, anesthesiology, medical students, a university affiliation. I don't like the commute, but I cover for them 8 days a month. That means I'm there from 6A to 6A, and everything that comes in, I'm responsible for. And I have done a myriad of cases, which allows me to keep my skills up. It provides what they need, and it provides what I need, which is the flexibility and freedom of my schedule and some autonomy. And lastly, this consulting business. This is, again, a screenshot from my website, and it allows me to do interesting projects and creative ways for caring for people. And because most of us are board certified in adult general surgery, it also validates and it diversifies my skill set. And most of you know, with a diversified skill set, you are more marketable. This is just one example of something, and I have this HIPAA here because for the longest time I never talked about who the patients were that I was caring for and what I was doing, but because this was broadcast live over the internet and it's all over social media, I figured I could share it. So my company was actually hired to be the trauma director for an event that happened in the Grand Canyon when Will Smith decided to heli bungee jump out of a helicopter for his 50th birthday. And so I assembled my team. In the back of this van was where we did all of the acute care and so forth. I had my malpractice. I got my Arizona medical license. This is the stunt crew, and there was a whole project that went into it that I don't have time to discuss. But here we are in the Grand Canyon, and then here is the team. And again, this is something that allows me to have my autonomy, diversify my skill set, increase my revenue stream, and not be beholden to one particular entity in these changing times. So what I would say, and I am right at 5 minutes, and my conclusion is that when times change in your environment, you can choose to accept or adapt or be innovative and creative. Find a need that exists in your community that also serves the needs that you need as an individual so you can care for the people who depend on you. And that's what I've done. And this is my office right outside of Philadelphia, and these are my 3 little people. Thank you very much.
Well, we're now officially out of time, but I don't think.
Refreshment. So if people want to.
Right, no, I was going to say, so we have this room, nothing else is coming in here afterwards, so we had hoped to have a few minutes at the end, and between the questions taking 30,000 seconds and so on, and me talking too much, whatever. We welcome questions and comments. We figure that probably everybody in this room has some experience negotiating their contracts. So we appreciate everybody's thoughts and experience. Please, we're waiting for you.
Peter Liebert, New York and Connecticut. I have recently transitioned from not an employee, but an affiliate of a multi-specialty group. And the reason why I transitioned was I realized that they were giving me too much in terms of obligation and taking too much of a percentage of my income. And therefore, I reestablished something that I had done many years ago, which is a solo private practice. I do limit myself to just 3 hospitals. I do not take emergency call because they have somebody else available at each one of those places to come in the middle of the night. And I think after many years of practice, that was not necessary. But the main thing was the financial obligation under which I was practicing as a member of a multi-specialty group. For a while, I thought they were actually paying my expenses until I realized that all of my expenses came out of what I earned and were deducted from whatever payment was left at the end of the month. That's a very disadvantageous situation. I just would like to add parenthetically that I've practiced in the same community that Dr. Stanford is in. For a number of years, I was the pediatric surgeon at Abington Hospital. I trained at CHOP and stayed on the staff at CHOP. And my first full-time job after training was at Jefferson. So I'm pretty well acquainted with that area. But I'd just like to add one more comment.
Please.
Because I introduced a resolution at the House of Delegates of the New York State Medical Society. And the resolution was not to call physicians providers. So I appreciate I appreciate the fact you already mentioned one thing, Barry, that is we are not being reimbursed, we're being paid if we are, and that we are not providers.
Yeah, clinicians is another word that's being bandied about very frequently. So, but thank you for your thoughts. Yeah, I would add, because there are a lot of different models, and I know of one practice group that actually signed off of every insurance contract because the HMOs had to pay them cash on the barrelhead, dollar for dollar, for what they billed for being out of network. And since they did not have contracts for the HMOs, they were not required to need copays or whatever. So if they billed $4,000 for an appendectomy or whatever, and they got paid 60% out of contract, they were able to take the 60%. They didn't charge the family, and they were doing a third of the work and making 4 times the income. So there are various models. I mean, I don't know that that's possible to work for everyone, and obviously I didn't join them because I wasn't sure about the sustainability. But there are still private practice models that can work. It's just becoming, I think, a little bit more difficult. Please.
Thank you. David Hackham, Johns Hopkins. So first a comment and then a question. My comment is thank you. And also when I negotiate, I'm the Surgeon-in-Chief at Children's Center. When I'm negotiating with faculty, I love having someone on the other side that is knowledgeable of the process, that has an attorney, that has thought about the rules of negotiation, and that recognizes that getting to a win-win is our goal, not compromise. And so these lessons are so helpful. And when I'm negotiating with someone that knows the rules, it makes my job so much easier. The question I have relates to your comment about cost. And I think you made the statement that hospitals don't know how much it costs them to provide the services that they then charge for.
Almost all.
Okay, so even with that, because I think it's true, but I think every hospital has to put a budget together, and that budget is influenced by nursing costs and supply chain costs and overhead. And so expand a little, because they're working from a place of knowledge, but I guess what you would say is that knowledge is incomplete, and we can maybe leverage that uncertainty in a negotiating position of strength as physicians. Maybe just expand on that a little bit, because I don't think it's the case that they don't know how much it costs. I think it's the case that those cost calculations may be incorrect. Your thoughts?
Well, if the cost calculations are incorrect, that means that they don't know their costs.
Yeah, I was giving you that. I'm not even sure that's true. Go ahead.
So I will give you an example, okay? Yeah. One example, for example, because Michigan actually does know their costs. They have an activity-based costing program that they basically know in an ongoing manner what it costs them to have a patient in the hospital for any particular day.
Right.
Now, most hospitals base their costs, which is their price, because they know the aggregate costs. As you said, they know what it costs them for nursing for a year, they know what it costs them for electricity for a year, they know what it costs for maintenance and planting trees and doing whatever they have to do for a year, and then they figure out how many patient days they have, and they take the aggregate number and divide it by the number of patient days, and it comes out to $1,000.53, and that's what they use to base their charges to insurance companies. The problem is that when a patient comes into the hospital on day one with pneumonia, and this is actually a published study, I have it somewhere in the 5 million folders on my laptop somewhere, but this is a published study, and what they found was that the actual cost for a first day in a hospital for pneumonia was very high. It was like $1,800. They had 2 nurses were in charge. They had to start an IV. They had to get the orders in. All this stuff had to get done, and a patient who was sick couldn't move. They had to get oxygen, respiratory therapy. Very expensive. Second day, patient's feeling better. All the initial intake stuff is done, costs much less. The third, fourth, fifth day, patient's better. Nurse come by, how you doing? Here's your meal. Starts the IV, gives them the medication, walks out of the room. They don't need as intensive care. So the third, fourth, fifth day, the marginal cost for those days is very, very low. But Medicare dings you if you keep patient in the hospital for 5 days. But if you know that it doesn't cost you more than $250 to keep that patient in the hospital for day 5 or 6, and they're getting better and they can walk, and you can send them home, and you reduce your readmission rate and you reduce your need for nursing home care by keeping them for an extra day or two, okay, you can leverage that to only bill, the hospital can use that to leverage, to not bill for 5 days, bill 4 days to Medicaid or Medicare, okay, and eat the rest of the cost because you know it's not costing you anything. And in an accountable care situation, you're saving a readmission, you're saving a nursing home visit, you're saving a lot of stuff. So knowing what your costs are gives you a lot of ability to then really play with those numbers. But most people don't even know what that is in their own institution.
That is so well said. Thank you so much.
David Klima, Boise, Idaho. I just want to caution everybody, especially when you're going with the RVU based. One of the things that we encountered as we were going through our negotiations, and we recently just started a new contract in April, was that RVUs were greatly inaccurate. And so we would have, especially me coming out of a place like Birmingham where I was doing a lot of stuff minimally invasive and we don't have the codes for those. I was doing a thoracoscopic CDH repair and getting 15 RVUs instead of over 100 RVUs. I was doing duodenal atresias and getting 23 RVUs instead of 42. I was losing almost 1,000 RVUs a year based on the fact that there was not a code and they would use this unlisted diagnostic, laparoscopy code or diagnostic thoracoscopic code. And so anybody that uses RVUs, you have to be very, very, very meticulous at reviewing those cases, in particular the ones that you know are going to make you a lot of money, especially as we continue to be creative and innovative and try to push the envelope a little bit. You have to be extremely careful with those.
Yeah, I just want to echo that. We had in our group to pay really close attention. One of our partners discovered that we were getting 0 RVU credit for every NUS repair we were doing. And you can imagine over the years how much that added up to. But I think across the board, most places still have issues with those unlisted codes. We track our laparoscopic pylorotomies, and at the very end of the year, however many number we have, they give us an adjustment to make up for that, because they're still able to bill for it, using the open code with a modifier, but from our side tracking, that definitely was an issue.
And that's the thing that we saw the hospital was getting paid, but we weren't getting credit for it. So
yeah, we track that as well, and every year it's between a 7 and 10% uptick. In other words, we do a reconciliation every 6 months, and then there's an additional 7 to 10% more RVUs that were given because we use so many of those unlisted codes.
Yeah, I think an important point is also to know that whether you're getting paid based on your RVU production or on your actual collections for those RVUs, because some places actually go by, you generate 1,000 RVUs or 10,000 RVUs and you get paid based on that, based on the overall group collection. I worked at a place where I generated 8,000 or more RVUs a year and was paid based on collection, which was mostly Medicaid. In Illinois, they pay very little. So, so you have to pay attention to every little detail of how that is going to work for you in your situation. And some places like Johns Hopkins, they actually have they have a published formal compensation plan. You can actually go into the literature, you can look it up, and you can see how they have it's a pre-made plan for how much of your stuff is going to be RVU based, how much of your income is going to be based on your value, value to the organization, value to whatever. And I think that right now, we still, as pediatric surgeons, provide a lot of value to hospitals, which is why we're getting paid much better than we used to be. It used to be the pediatric surgeons were always the poor people. For most of my career, we were paid less than everyone else because 50 to 80% Medicaid doesn't pay your way. And suddenly, pediatric surgeons are among the better paid general surgeons, where our average salaries are actually higher than most adult general surgeons. And that's being driven by a market. That's being driven by, first and second tier hospitals that need pediatric surgeons to cover their units. But I am telling you that as we populate more and more pediatric surgeons with 60 programs extant and 40 graduates or more a year, sooner or later that tipping point is going to be reached when all those little spots are filled. And suddenly we're going to have people who are out there looking for jobs and there are not going to be any jobs, and they're going to start working for a lot less, and people are going to figure that out because hospital administrators, as dumb as they may be relative to the average IQ of a doctor, okay, Sooner or later, they will figure that one out. And when that happens, we may all be in trouble because, as I said, our value is only as good as what we're able to provide for the organization. And if we're not providing that value by being the only pediatric surgeon they can find, we're going to be
Supply and demand.
we're going to be in trouble. Exactly. Any questions? Any other questions for anybody? Any other comments? I thank you all for coming. Really.